we are going to continue where we finished with the lecture about the non-specific asymmetric density with a very slight architectural distortion. And then we called it radial scar. One after the other is going to be asymptomatic woman. I think I would tease you if I was asking you whether you would call her back. But because you have your telephone fired up, would you mind telling me, if you had this case in front of you, would you mind calling her back? MLO and CC projection. But then you would immediately throw at me my own teaching, enlarge the picture. Okay, then I'm going to uncover for you that it's the left breast. Look at how harmonious and beautiful the lower half of the picture is. There is something wrong here. And is there something here? Question mark. You would say, oh yes, I think there is something here. Now, those of you who use tomosynthesis would see and pick it up easier, but the enlargement is working very well. Now, here we have something, and then we would say, let's take the calcification separately because they don't belong here. So it's an architectural distortion, and as we know, this was not palpable, so I immediately say, she didn't have surgery, she didn't have trauma. Traumatic fat necrosis out of the picture. What is the second one? Could this be a radial scar? It could be. And because it's close to the surface and it's not palpable, and I'd say, I got a point supporting the radial scar. Otherwise, watch out. Is this a BCMO, a cancer of mesenchymal origin? Is this DAB? No, I don't think so. Well, what would help you? Well, something is in our toolbox. Do you think MR would help you? Well, think it over 5 times before you think you get help from MR in radial scar. Because there are the fresh radial scars which increase metabolism while it produces the side branches, then it might be kind of positive. But if it's an old one with a big fibroelastic core, that is not going to help you. I think I would first go for ultrasound, because now you have those beautiful pictures of 3D in your mind. What do you think? This is the automated breast ultrasound. This rather suggests that's a cancer. No, handheld ultrasound. I need very thin, cigarette paper thin slices, and I got it. Dear colleagues, this is a duct. This is a duct. This is a duct. Small cyst. Does this look like a BCMO, diffusely invasive lobular carcinoma? Absolutely not. Is this a little bit hungry? Yeah, sure. Hyperplastic breast changes need blood supply because they have metabolism. And I would not stop at these slides. I would take more slides because I say, I think I got it. This is going to be a radial scar. Great. Did we talk about cystic cavities? I just got it, right? Tell me, does cancer look like this? Stellate lesion, circular? Absolutely not. This is all fluid. And Doppler is fine. This is radial scar. Isn't that interesting? You see, MR didn't help you. Yeah, we know that there is something that picks up the contrast media, the gadolinium. No. And because we had a discussion, is this really radial scar, and so on and so on. Unfortunately, we did this. We talked about, don't do it unless, there is doubt. And what do you think you get? Hyperplastic breast change, benign, says the pathologist. And he also says, send me more. Because you gave me tissue from here. But I don't know what's in here. I don't know what's in here. Here is the result. Did we talk about fluid-filled duct-like structures? Yes. Here is one. Did we talk about cystic cavities? Yes. You see? And here is blood in there. Here it is. And it's fibrosis. So proliferating duct cystic cavities plus fibrosis. No associated malignancy. I cannot rule it out. We need to deliver every radial scar to surgery. Here is the specimen. No malignancy seen. So I'm going to a little bit speed up, work with me. I don't even ask you whether you would call this patient back. Do you see the architectural distortion? Yes, you do. Where is it on the CC projection? Very close to the skin. Skin is here, and it's not palpable. We can speculate whether this is going to be a DAB or radial scar. It's not very black. I would have expected, probably now it's more of a black star here. You see that? I mean, I'm just drawing it white. But what is this? In these cases, I would probably go for a core biopsy, or why not this one? And I still don't know. I know that this is not going to be a breast cancer of mesenchymal origin, first of all, because it was localized. You remember, BCMO is the disease of the very structure of the breast. We learned that we should analyze the central portion and we should analyze the radiating structure. The AAB of this size would have this big central tumor mass and very determined straight Eiffel Tower-like spiculations. No, this is not. This is a finger. This is a finger. Finger is duct. So now I don't know whether it's DAB or a radial scar. Pathologist is going to tell you. And this is the tricky part. The central fibroelastic core was too big. But you see, if you are aiming with your core biopsy here, you're going to miss this one. This is not cancer yet, but epithelial instability, hyperplasia. There are several layers of cells. If the surgeon only takes out this one, this is still a ticking time bomb. Not a very aggressive something. You know that. Nevertheless, you see, here are the cell proliferations at the periphery. Pathology says that's still not a cancer. So let me show you one case after the other. 69. Now I'd like to call for your telephone. At this time point, when she's asymptomatic, would you call her back? And I'm not fooling you. This has pathology for the right breast or for the left breast. And then, of course, you have already looked at the axilla, and after that, you go side by side, step by step, little overlapping like this. And because it has some density, you look at the contour too. I'd like to ask the question, would you pull her back at this time point? 50-50 means tremendous insecurity. And, we agreed upon that you should have a little notepad and a pencil, jot down 56% of you wanted to call back for the right breast. Then we get back, and let me say at this time point, we did not call her back. You want to call back for the right breast. What is going to happen? It's in the left breast, here. You see, there was an architectural distortion here. I shouldn't blame anybody. We passed by because we didn't enlarge at that time point. Here is the architectural distortion. Did I tell you it's going to be difficult to find? Of course. This is the name of the architectural distortion, perception. This was earlier. This is now. Is it increasing? We make the mistake that we magnify, not enlarge, but magnify architectural distortion. Then it seems to disappear on the MLO projection, but it became very obvious on the CC projection. Now you're standing in front of this. You already called her back. Two things you are going to do. First of all, history. No, there is no trauma. No surgeon was causing a scar. Traumatic fat necrosis out of the picture. Then you palpate. And here is the skin. And you have this huge architectural distortion. You know very well that the BCMO is always super palpable. And also, the proliferating ducts in DAB have a content, a solid cancer content. That's going to be palpable too, but not this one. I didn't say this is the 100% diagnosis of a radial scar, but I just got a little support. Now we go for 3D automated ultrasound, which shows architectural distortion. Tomosynthesis and 3D automated ultrasound are going to show architectural distortion well. You put the cursor there and you still don't know whether it's cancer or radial scar. Do we need the handheld ultrasound? I'd like to. Here is the handheld ultrasound. Did it help? No. So then comes the needle. The surprise is here. Not very big surprise, because we talked about it. 10 to 40% of the cases of radial scar might have some epithelial cell proliferation on the step wedge. That is grade 2 cancer in situ associated with radial scar. No wonder this showed the active radial scar. And this was interpreted as physiologic changes. Very tough. Your other MIP images, the MR doesn't help you in a diagnosis. It helps you in determining the extent or guessing the extent. It shows that it has a radiating structure. We knew that. Do you think that this is going to provide much enough tissue? Did we cut through? Give me magnification. Well, we shall see. This one, the histopathologists don't like. Can you imagine when the microtome is slicing and it hit a piece of metal? Fish this out before you put the tissue into the microtome. So at this time point, what would you say? Educated guess? It could be a radial scar. Did we learn that the radiologists have to look at the black in order to see the white? Did I say this was the final diagnosis? No. I'm giving a hint because of non-palpable, because difficult to detect, spider's web-like, and so on, and because of these black holes. I put my money on radial scar. You got it. This is a radial scar. Now you see how important it is to do something I think none of you do. Namely, the fresh specimen comes back to you and the slices, fresh specimen slices come back to you and you take a picture. Look at that. Now it's very close to the picture of a large section histology, and it's quite extensive, and of course they cut through it. Here is something I don't think, and I hope you will never see. I saw 2 or 3 in my life, that a grade 3 DAB is associated with radial scar. This is aggressive, and this is a duct. Grade 2 and grade 3 neoduct genesis, not DCIS. DAB associated with radial scar. Look at it very carefully. You will never see it anymore in your life. Happens very, very seldom. Tumor field margin 19 millimeter. It's an ice break. Do you see an architectural distortion? Of course we see an architectural distortion, but then you start to scratch your head and say, is it real? Is it true? The answer is yes. But then when we learned the analysis tricks of anything that is radiating, you look at the central tumor mass, which lacks here. There is none. This is cancer, the white star. And then look at the Eiffel Tower, which lacks here. It's kind of catch me if you can. I cannot say it's not a radiating structure, but I don't know what to say. Well, I would say give a chance for radial scar. And there is one more thing. You know, the cancer is a three-dimensional object. This one, you change it from projection to projection, and it changes. And these calcifications, don't worry about them. They are skipping stones in fibrocystic change. Doesn't it have a very big central fibroelastic core? Might not. Take it out. No fibroelastic core. It looks like this. And this is an interesting staining. This is the elastic staining. Do you remember I mentioned to you that the pathologist, John Azzopardi, called radial scar sclerosing ductal proliferation or hyperplasia? And the sclerosing means just this, the black here. That is elastic staining. We see it because of the fibrous elastic tissue. The black star is because of the content of the proliferating ducts. Do you see an architectural distortion? Of course you see it because you immediately lock your eyes on the Milky Way, and there is once again a very tricky, hardly visible architectural distortion. And I don't go through the steps now, the history and traumatic fat necrosis ruled out. Should I call this a tent sign? In a better day you can, but otherwise this is too big. Here it is. Now it's black. You see? Black star. Quite a sizable central fibroelastic core. Now we need a skillful pathologist who is not going to overcall this. Hyperplasia, this is lobular cancer in situ. You remember what lobular cancer in situ was? Here are the normal acini, and now the acini became a little bit distended, and within that there are these extremely monotonous, very low-key cells. Every nucleus looks exactly the same, but it's still a finger. You see, this is one finger, this is another finger. The grade 1 cancer in situ already produced the fluid, the fingers are gone. The grade 2 makes a ball out of the TDLU. Lobular carcinoma in situ associated with radial scar. Should I really scare this poor woman that she is a high risk? No. Tell her that you want to see her. Whenever I ask you to come, please come. Don't hop over. This is not a precancerous disease. Hagenson was an ingenious American surgeon working in New York. He wanted to talk the medical community out of calling it carcinoma. Lobular neoplasia. Medical community doesn't listen. Do you see an architectural distortion? Oi, this is very difficult. But here is no problem because we don't like acute angles. Here is a radiating structure. I don't see central tumor mass. And on a better day, I would say this is a black star. For two reasons. Too big for the lack of the central tumor mass. Here it is. Isn't it beautiful? Enjoy the proliferating ducts. Pretty skinny, no cell proliferation, nothing. But the lesson is here again. If the surgeon was cutting just this one, then you would miss these cell proliferations at the periphery. I'm very sorry. The powdery calcifications and the radial scars are quite a nuisance, quite a lot bother us. You see the central portion where you put the needle, there is just fibrosis. The more you go to the periphery, the more cells. That's why, unfortunately, we have to take out the whole thing. Is this just hyperplasia? Is this in situ? Excuse me, 27-year-old woman? High risk for developing breast cancer? This is the breast of a young woman. And once again, look at the black in order to see the white. And this is harmonious. As soon as the cancer is growing out of this TDLU, it's going to grow at the expense of the fat, or we are going to have the iceberg phenomenon or calcifies. I don't think I see much here. Would you say that there is something here? Not on the MLO. Tell me whether you would call her back. She's asymptomatic now, but she's coming to us because very heavy breast cancer history in the family. I'm asking you, here it is, asymptomatic, very nicely positioned. There is one trick we learned, but let me see. Right breast, you are a genius, but I'd like to know why. And this would be your answer. Every dense breast we should look at like this. Contour, stop at 5 centimeter, and go here, and you would say, there is a notch here. And I don't see anything behind it. Nevertheless, that's the area of interest, and I provoke it, which means I'm pushing it, and it doesn't go away. Now, this is real. Now we have to be serious about it. What would you do? Well, of course, you palpate it, and you don't find something. Now, be careful. You are influenced. High risk family. You only think about cancer. Would you mind putting this on the back burner? There are benign cancer mimicking lesions as well. And this one, for my eyes, is a radiating structure. And it's so big, and I still don't see a central tumor mass. Do you know why I'm thinking like this? Because I just hate to think about cancer to begin with in any woman. Definitely when a 27-year-old woman is in front of me. Could this be a radial scar? What? 27-year-old? Can happen any age. Let's see. My favorite tool let me down. The suspicion of cancer is still there. Okay, fine. Give me the needle. And it says radial scar. What? Is this a radial scar? Sure. What are we going to do? Well, I tell you, we are going to take it out. 27 or not. Doesn't matter. That quadrant comes out. Because that's an epithelial instability in a woman who has high risk. So, here we have cells. Now I'm on my toes when I'm talking with the pathologist. When you have columnar cell hypoplasia in a core biopsy, that's not enough, because you might hit this part and this one is still behind. You see what I mean? You really have to go for it. And don't be nervous, and don't tell her that this is a big deal, because this is happening in the acini. So it's not the major duct. In the DAB, there is no columnar hyperplasia. Do you remember? Duct, one step, normal, and grade 3. In the acini, there is the step wedge. A little bit back, a little bit forth, and so on and so on. So, and then he asked, what about a 6-month follow-up? That's not my favorite, because on the step wedge, things happen slowly. It stays for a while, and when she or you got tired of following her for 3-4 years, then comes the hockey stick effect. That is the differentiation. Go for it, take it out, and now everybody's relaxed. Very nice margin, and the epithelial instability is in the bin. Now I'm just wondering whether you see something she felt. Very difficult. And you know, it's not there where the BB points out. It's actually here. What? You want to show me a palpable radial scar? Yes, I'm going to do that. It looks like cancer. It looks like a AAB, central tumor mass, short speculations, right? Sure, it looks like. It walks like and talks like cancer, correct? Sure. We are going to put a needle into it and we take it out. And do you know what this is? This is a totally burned out radial scar. Totally hyalinized. Dear colleagues, that's why I'm showing you so many cases, not because, oh, here is another case. Every single case is different. This is elastic staining. There are no epithelial cells left. This is a burnout radial scar. All these different staining methods support this statement. Used to be some hyperplasia, not much left. This is a huge radial scar my friend David Neeland from Montgomery, Alabama gave me. You know what is striking here again? There is a hole in the bucket. Don't think about cancer immediately. This is a huge radial scar. Very difficult to negotiate with the surgeon to take out so much. Sure, your responsibility. You are not allowed to take out this much. This much has to go out. You see how much it changes from projection to projection? Radiating structure when the teacher told the kids lay down on the marble floor in the museum. Very definite architectural distortion. I'm not speculating. Palpate it, couldn't palpate anything. Suddenly it's black. It's not only that what I'm looking for. I'm just telling like a broken record. Look at the radiating structure, and that's where I say, this is going to be black star. And then corresponding to this size of invasive carcinoma, we would have this kind of solid central microlobulated tumor mass. That's not. So the mammographic diagnosis is very much possibly a radial scar. Black star. Here we go. And then you're scared because there is so much cell proliferation. Fine. But this is all hyperplasia. Do you see the notch again? Still not palpable. Large. Look at the black in order to see the white. There it is. Once again, the radiating structure is too large to be a cancer. And I think it's black star. See these. Let's look at it. There is quite a sizable central fibroelastic core. Here it is. The more you go towards the periphery, the more cells you find. In the middle, fibrosis. Different stainings again. This is elastic staining. Isn't it fantastic? Try to ask your pathologist. This is going to be difficult. Nevertheless, there is an architectural distortion, and we have to deal with it. Here it is. And interestingly enough, this is like teardrop-like openings. This is cancer. But at the end, on the top of the step wedge, the good cancers are, and this is one, tubular carcinoma, for example. Tubular carcinoma associated with radial scar. That explains the central tumor mass. Well, I have two findings. The calcifications, and I think it's a black star. Once again, the size is this big. Where's the central tumor mass? Instead, I think this is black. Well, you think whatever you want, you just have to do the job. And you think there is a central tumor mass, but actually when you compress it, it's gone. Could be a cyst, yep. And this calcification, we can deal with the calcifications later on because so much has to be removed. radius scar without any associated cell proliferation.